grateful to each one of you who are present today for this session on their Sundays. It shows our commitment, and I will try my best that in this session, I will provide you some very focused summary of pediatric resuscitation. About myself, I am Jabeen Fayyaz, pediatric emergency medicine staff physician in the Hospital for Sick Children, and associate professor at the University of Toronto. So I will just very briefly, I know I'm skipping a couple of slides, but it is the summary of the last session that what we discussed in the last session is PAT, which is the Pediatric Assessment Triangle, where we did a lot of cases and talk about how important it is appearance, breathing, and circulation, which is your PAT. Anytime you enter and start assessing a patient, PAT is the first thing you are going to do. And we talked about in appearance, the mnemonic is tickles. Tickles, which is tone, interactiveness, consolability, look, gaze, speech, and cry. In breathing, you will look at the work of breathing, abnormal sounds, retraction, head bobbing, and in circulation, you will see the pilar, mottling, and cyanosis. So this is what we talked in nutshell, and then followed by A, B, C, D, E, which is your primary assessment, and the sample history followed by your head to toe examination. This is what we all talked in our last session, and what I'm hoping today is to talk about the major like a lot of components of the PALS guideline, which has changed in 2020. Our new change is expected in 2025, September to November time. But if, as per our last communication, the updates will come in November 2025. But as we know, it's only updates. The core concepts of PALS guideline will remain the same. It is just based on literature. They will tell us what extra or what additional point they have found out. So I know we are talking about right now 2020 guideline major updates, but I'm hoping once the 2025 guidelines are announced, then we will still be able to do another session on it just based on the updates. But meanwhile, what we are talking about is what is the major focus of 2020 guidelines. I will still need a lot of your interactiveness because I have a couple of cases where I need your input. So with this preamble, let's deep dive into the major updates in the 2020 guidelines. What they did, there are four major things that happen. They did algorithmic revisions. They have make the shock management and cardiac management more evidence focused. They include or put an emphasis on the chain of survival as well as post cardiac arrest care, and there were some ventilation or airway updates. So these are the major updates, and we will talk about it one by one. First is the chain of survival. And as I said, please, if any question comes in, if you have any comment, please continue typing in the chat. I have it open on my second screen and I'm paying attention to it, and I will address it as we will go. So coming to the chain of survival. So chain of survival, ACA and OCA is in-hospital cardiac arrest and out-of-hospital cardiac arrest. So there's always an emphasis on early recognition, activation of the emergency response system, high quality CPR, advanced resuscitation, and post cardiac arrest. But there's a lot of emphasis on recovery. And we will talk about it in the later part about recovery, like short term, long term, ultra long term. Remember, when pediatric patient goes to cardiac arrest, they are very young, and there's a whole bunch of recovery recovery that is expected from them. So they have a lot of emphasis that in addition to improving all the processes that include early recognition, providing the best, oh, sorry, I thanks for reminding me, whoever has reminded, I will make it proper. I appreciate that. Let me try to take care of it. Is it okay now? Perfect.
Yes.
So, whoever I think Uroli has mentioned, thank you so much. Appreciate it a lot. So, what I was saying that a lot of emphasis is on the recovery phase of the pediatric cardiac arrest. So, now coming to the airway. First, we will start with the airway because airway is A, and it's the most important thing to be taken care of. So let's start with a case, and I would like to have your response, and you can say A, B, C, D, or 1, 2, 3, 4 on the responses. So you have a 9-month-old child who presented to the either in the emergency department or urgent care center. He is having fever and some upper respiratory tract infection and looks unwell. The baby has pulses present, but very inadequate respiratory effort, and you decided to give rescue breath. So what should be your rate of rescue breath based on 2020 guidelines? One breath every 3 to 5 seconds at 12 to 20 breaths per minute, one breath every 2 to 3 seconds, one breath every 5 to 7 seconds, and one breath every 1 to 2 seconds. So thank you so much those who are putting their responses. B is the most commonly defined response. You all are correct. It is one breath every 2 to 3 seconds. That is 20 to 30 breaths per minute. So what is the reason? In 2020 update, the recommendation is to give one breath every 2 to 3 seconds. That should be 20 to 30 breaths per minute, which was not the case in the previous guideline. Because in pediatric patient, the most common cause of cardiac arrest is respiratory as compared to the adult patient, where the most common cause is cardiac in origin. So there is a growing evidence of pediatric specific patients population that support that you should give more airway support. That's why the rate of giving rescue breath has been increased to one breath every 2 to 3 seconds instead of one breath every 3 to 5 seconds. Now, coming to the second question. Now you have given the rescue breath, you have decided that you will intubate the patient. So if you have your nurse or your resident ask you after intubation, what do you want me to do? What is the rate of breathing would be? And the options are almost the same. One breath every 3 to 5 seconds, one breath every 2 to 3 seconds, or one breath every 5 to 6 seconds, or 1 to 2 seconds. What is your response now? You have now intubated. Before, you are just doing the bag mask ventilation. Perfect. Thank you, everyone. Perfect. So yes, all of you are correct. It is one breath, still one breath every 2 to 3 seconds. So why? Because new data has suggested that higher ventilation rate, that is 30 breaths per minute in less than 1 year and 25 breaths per minute in older, is associated with improved return of spontaneous circulation and survival in hospital cardiac arrest. So therefore, now it does not matter whether you are giving a rescue breath or you have intubated the patient. Your rate of giving ventilation will remain the same. That is one breath every 2 to 3 seconds. That will make it 20 to 30 breaths per minute because it is associated with improved return of spontaneous circulation and survival. So while you are preparing your equipment, the patient become apneic and your respiratory therapist ask which tube you will select. Remember, this is a 9-month-old child. So what is your choice? Cuffed ET tube or uncuffed ET tube? A or B here? Uncuffed ET tube, okay? B, okay? So as per the new updates, it is cuffed ET tube. It is like in the old guidelines, 2010 guideline, it is said both cuffed and uncuffed ET tubes are acceptable. But what they did in the most recent, which is 2020, let's see what their recommendation will be in 2025, is that it is reasonable to choose cuffed ET tubes over uncuffed ET tubes for intubating infant and children, because they are saying that cuffed ET tube is safe, it decreases the need of tube change, it decreases the rate of reintubation, it decreases the risk of aspiration, and the rate of subglottic stenosis is rare when cuffed ET tube with careful technique is used. So what is our practice at SimKIDS? That definitely after 3 months, we use cuffed ET tubes. We are not using uncuffed ET tubes in children more than 3 months. But as per the PALS recommendations, it is safe to use cuffed ET tubes after the neonatal period. And remind you, the PALS updates are after the neonatal age. For the neonatal resuscitation, there are separate guidelines. So the new recommendation is cuffed ET tubes are safer to be used in pediatric patient as per the last updated guidelines. While you are intubating, your colleague advised for the cricoid pressure. What you would do? You will apply the cricoid pressure, or it is not recommended as a routine. Any thoughts about it? Not recommended as a routine. Thanks, Aisha. Thanks, Imran. Thanks, Shurvali. Perfect. So, yes, you are correct. It is not recommended as a routine, which was in the previous one. Routine use of cricoid pressure is not recommended during the endotracheal intubation of pediatric patient, because routine use of cricoid pressure has been found to be associated with decreased intubation success rate, and it does not decrease the rate of regurgitation. That is why, already in resuscitation you have so much of time pressure things, and if you assign one person just to put a cricoid pressure, you are just need another set of hand, which is not always possible. So it's no recommendation for a routine use of cricoid pressure. So while the ET tube intubation was being done, the baby went into cardiac arrest. CPR was started and epinephrine ordered. So what is the 2020 recommendation about the timing at which it should be administered? 3 to 5 minutes, within 5 minutes, or after 5 minutes? 3 to 5 minutes, okay? And then this is based on American Heart Association guidelines. I understand that there are some differences in the European guidelines, in the Australian guidelines. So please follow the guidelines. I'm just coding or quoting the American Heart Association, APLS, which is Advanced Pediatric Life Support, based on the AAP, as well as Heart and Stroke Foundation. So please do not feel, oh, in our guideline based on European and Australian guideline, there is something different. That is okay. There are some differences, but I think the most important thing is to focus that what is the rationale, and then do accordingly. So I'm looking at a lot of 3 to 5 minutes. So what is now the recommendation is as early as possible. That is within 5 minutes. It is still 3 to 5 minutes, but before it was start CPR and then give epinephrine. I will show you the algorithm when there are changes in the algorithm. But now the recommendation is as early as possible, but yes, within 5 minutes. So what the 2020 guidelines said, that for pediatric patient in any setting, it is reasonable to administer the initial dose of epinephrine within 5 minutes from the start of chest compression. So therefore, if you know that your patient is coming, sometime EMS give us heads up, we already prepare the epinephrine doses if we know the age of the child or weight of the child. So for every minute delay, this is what the research have shown, that for every minute of delay in administration of epinephrine is associated with decrease in return of spontaneous circulation, that is your ROSC, decreased survival at 24-hour, decreased survival to discharge, and decreased survival with favorable neurological outcome. So you do not have to wait till 3 minutes. You can administer as soon as possible the epinephrine first dose. This is the algorithm where they have changed that if you have asystole, like I'm talking about the unshockable rhythm, it is like asystole or PEA, administer epinephrine as soon as possible. So it has gone from the algorithm in as per the 2020 updates that within 3 to 5 minutes. Now it says as soon as possible. So remember, this patient is our 9-month-old baby who come in with respiratory distress and URTI symptoms, later on become bradypneic with decreased ventilation, and then you have managed it. So baby had a ROSC, a return of spontaneous circulation, and then get admitted to the PICU. So, what are some of the updates? So, that is always assess the respiratory effort and its effectiveness. The time of the ventilation is one breath every 2 to 3 seconds and maintain at the rate of 20 to 30 breaths per minute. In the pediatric basic life support, assess the response, check if child respond to verbal or tactile stimulation, check breathing, check pulse, and if pulses are absent, always start CPR. And we will talk more about the CPR. Then in the open the airways, head tilt, chin lift. If there is no trauma, if trauma, then jaw thrust. Basic life support adjuncts, that is oropharyngeal and nasopharyngeal, and then proceed to the advanced airway support. So in the back mask ventilation, it's always the first line approach for most pediatric patient. Ensure proper seal and visible chest rise with each breath. And our plan is to take a detailed lecture on the airway management, and we will talk about in that how to maintain a proper seal, what are the maneuvers, how to measure the oropharyngeal airway size, nasopharyngeal airway size, and therefore we are just telling you the basic higher level thing as it is focused on the PALS update. And the advanced airway management is with the back mask ventilation. If it is ineffective, you will go for the either LMA, which is laryngeal mask airway, or ET tube intubation. Always remember, avoid excessive rate or volume. Too much ventilation can causes also decreased cardiac output and impair cerebral perfusion. So always remember, when you are doing a bag mask ventilation or endotracheal intubation, just put the orogastric tube and put it on decompression. Because if you are pushing air, remember, air in addition to going into lungs will also go into stomach, and it will continue to inflate the stomach and cause abdominal distension, which will push your diaphragm up, and then the lung volumes will not be enough to expand enough to provide a proper ventilation to perfusion ratio. So this is all about airway. Now coming to the chest compression updates. In the chest compression guideline, they have emphasizes on the 5 component of high quality CPR. What are the 5 component of high quality CPR are? These are 5 component, that is adequate chest compression depth, optimal chest compression rate, minimize interruption in CPR, allow the full chest recoil, and avoid excessive ventilation. So what are they saying? Compress 1/3 the AP diameter of the chest. Optimal rate, maintain 100 to 120 compression per minute. Allow the chest return between compression, because think of heart as a kind of bag. If you compress it and then do not allow recoil, the blood will not fill in enough to pump the blood all over the body. And minimize interruption, limited pauses to less than 10 seconds. So these are the 5 components of high quality CPR. One important thing which we sometimes miss or do not pay attention is the surface during CPR. There is a lot of emphasis on using firm surface while doing a CPR. because there are multiple studies, but one studies to quote here is there are meta-analysis of 6 major studies showed a 3 millimeter improvement in chest compression depth when a backboard was used. It is a simulation based study and done on the mannequin, but all the feature or factor were controlled. So you can imagine how important it is to put a firmer surface when you are doing a CPR. So please, please, please do not forget to put a hard board when you have to start a CPR. Doing CPR on a soft bed or soft surface is equal to not providing, because all of your chest compression pressure will go on the mattress and it is not enough to compress the heart properly. About the energy dose. The initial dose of 2 to 4 joules per kg. Yeah, it is of 2 to 4 joules per kg of monophasic or biphasic for defibrillation. But for ease of teaching, an initial dose of 2 joules per kg was recommended. And for refractory VF, increase the defibrillation dose to 4 joules. So what is that? Like if you remember in the algorithm, you will start from 2 joules and you can go up till 10 joules per kg. And the first energy dose is 2 to 4 joules. But us, for the ease of remembrance and teaching, we just use 2 joules as a first energy dose, and then we go for 4 joule, 4 joule, 4 joule. But if you are using first as 2 joules, second as 4 joules, third as 6 joules, and then up till 10 joules per kg or adult maximum dose, that is also correct. So it's our personal choices, but always remember that the first initial dose of first shock is 2 joules and the subsequent is 4 joules per kg. There is a lot of emphasis on monitoring invasive blood pressure to assess the CPR quality. In 2020 update for patient with continuous invasive arterial blood pressure monitoring in place at the time of cardiac arrest, it is reasonable for provider to use diastolic blood pressure to assess CPR quality. But for us, we do not do it in the emergency department. It all happened in the pediatric intensive care unit. So it is more applicable to our PICU setting, because a new study shows that among pediatric patients receiving CPR with an arterial line in place, rate of survival with favorable neurological outcome were improved if the diastolic blood pressure was at least 25 millimeter of mercury in infant and at least 30 millimeter of mercury in children's outcome. And I will emphasize this is not no, there's not a lot of discrepancy in PALS and APLS as far as I know, Fatma. But if you have noticed something, please mention it specifically. But there's no discrepancy. The recommendation is you can go from 2 to 4 joules per kg and up till 10 joule or adult maximum. This is the broader recommendation. What 2020 guideline has said that start with 2 joules per kg for the ease of teaching. Then you can, second shock could be 4 joules per kg, and it is up to you afterward. You can continue 4 joule, 4 joule, 4 joules, or you can do 6 joules, 8 joules, 10 joules. What we practice at SimKIDS is we do first shock as 2 joules per kg and second, third, fourth, subsequent shock as 4 joules per kg. We do not continue to increase. The reason or rationale behind it that increasing the energy of shock does not make any difference, and it will continue to put a cognitive load on you. You will start looking for other causes like HNTs and continue the shock energy as 4 joules per kg. And it is institutional preference. If you are using 2 joules and 4 joules versus 2 joules, 4 joules, 6 joules, 8 joules, both are correct practices. As I said again and again, these are institutional preference. No, I do not find any difference based on my understanding. But as I said, I am quoting only the North American guideline. Maybe the European and Australian guideline have some differences. Now, going to the other recommendation, if arterial line is in place, then continuous measurement of arterial blood pressure may improve the CPR quality. And after ROSC, always remember to do a seizure evaluation and treatment should be considered if indicated. Now, going to the next step is the shock management update. The shock management update, there's a lot of emphasis on obtaining the circulation, that is IV or IO. There is a lot of emphasis on administrating the first dose of epinephrine as soon as possible with repeat every 3 to 5 minutes and consideration of other medication which can be used in shock that we will talk with each algorithms. Defibrillation for shockable rhythm, as we discussed, 2 joules increase to 4 joules for subsequent shock, minimize the time between compression and shock delivery. The shockable rhythms are your ventricular fibrillation and pulseless ventricular tachycardia, while non-shockable rhythms are asystole and pulseless electrical activity. So in shockable rhythm, your priority is to do defibrillation along with CPR and medication, while in non-shockable rhythm, your priorities are epinephrine as soon as possible, CPR, and then underlying causes in both, which are your H's and T's. And H's and T's are, the 5 H's are hypovolemia, hypoxia, hydrogen ion, hypoglycemia, hypothermia, and for T's are toxins, tension, pneumothorax, tension like in the pericardium, like tension, it's, I forget the name, but when there's a fluid around the heart, you can have that, and then any trauma and toxins, as I told you. So fluid resuscitation, I'm skipping this because I really want to go to the cases and I will come back to those slides. So let's, yes, tamponade. Thank you so much, Zainab and Nusrat. Cardiac tamponade, which is an equal part of tension pneumothorax. So let's go to this case. You have a 2-year-old baby with fever, vomiting, looking lethargic. Heart rate is 180 per minute. Respiratory rate is 28 per minute. Temperature 39 and blood pressure is 80 by 55. Remember our formula that we talked about last? 70 plus age times 2 is the minimum blood pressure that you need for a patient to be called compensated versus decompensated shock. So you can measure whether the blood pressure in the compensated range or decompensated range. So this is a 2-year-old baby with fever, vomiting, looking lethargic. Heart rate is 180, respiratory rate is 28, temperature 39, blood pressure 80 by 50, CRT 3 to 4 seconds. And do you think this patient is in shock or not in shock? Yes or no? Please respond in the chat. Yes, perfect. Because the child is tachycardic, child is febrile, capillary refill time is very prolonged. So you decided to give fluid. So how much fluid you will give? 10 to 20 ml per kg, 5 to 10 ml per kg, 10 to 15 ml per kg. I know it is very contextual, but I will tell you this patient does not have any cardiac history and the child is not malnourished. So these two things, no cardiac history and the child is not malnourished. 10 to 30 ml per kg, 10 to 20 ml per kg, A, most of, and then some 5 to 10, I will say, C as well. So yes, most of you are correct. It is 10 to 20 ml per kg. So what is the difference? Before in the guideline, it is like you will give 20 ml per kg, 3 boluses, like 20 ml per kg, 20 ml per kg, 20 ml per kg. But now what they have suggested that in patient with septic shock, it is reasonable to administer fluid in 10 or 20 ml aliquots with frequent reassessment. You have to reassess after each fluid because there are 2 randomized controlled trial of the patient with septic shock with those who receive higher fluid volume or faster fluid resuscitation were more likely to develop significant fluid overload signs characterized by use of mechanical ventilation and worsening oxygenation. So, therefore, the emphasis is to give smaller aliquots, that is 10 or 20 ml per kg, and do reassessment. And what you should be looking for in reassessment, I would say three things. One, improvement in heart rate. Second, basal crepitation. And third is your liver. And if you are using point of care ultrasound, then you can use point of care ultrasound to look for the intra IVC as well. So the emphasis is you will give 10 to 20 ml per kg of fluid in smaller aliquot, but you have to do frequent reassessment. And in frequent reassessment, check three things at least clinically. First is basal crepitation. Second is your heart rate not getting improved. And third is liver push down. If any of this is present, that it means it is showing the signs of fluid overload, then you do not have to give more fluid. Look for alternative. It could be a cardiogenic shock, or it could be that child does not need more fluid. It is a pump failure and you may have to start the inotrope. Therefore, it is very, very important to give fluid, but in smaller aliquots with frequent reassessment. So now go to the second question. You given fluid, you did reassessment, but the child remained tachycardic like after two boluses or three boluses, and you plan to start inotrope. So what is your choice of inotrope? Epinephrine, norepinephrine, dopamine, dobutamine, and it could be more than one correct answer. Yeah, I'm seeing epinephrine, norepinephrine. Perfect. So the as per the 2020 guideline, it is reasonable to use either epinephrine or norepinephrine as an initial vasoactive infusion. Two randomized controlled trial comparing the escalating doses of dopamine or epinephrine demonstrated that when epinephrine was used, there was improvement in timing of resolution of shock, and the 28-day mortality with the epinephrine use was better over dopamine. So if you have everything available, then epinephrine is a preferred choice. But if you do not have epinephrine or norepinephrine available, then epi and norepinephrine, then dopamine is a alternative, is a reasonable alternative. So what we do at our emergency department, just to simplify things and just to minimize medical error, and just for the sake of our nursing training and for our junior training, we use epinephrine as a journal inotrope, as a first line inotrope. And yes, there is no harm in using norepinephrine if you think that is a better choice. The whole concept of warm and cold shock, now there's a lot of de-emphasis on it because it always confuses us, that is it a warm shock, it's a cold shock, and then there's a lot of discrepancy. You still can consider doing it, but for the simplicity's sake, the PALS update has now simplified things by saying epinephrine as first line inotrope is a reasonable choice. But if you are using norepinephrine, that is not wrong as well. But if you do not have both of them available, then use dopamine as a first choice as well. So you have started epinephrine, and the child remain the same, the shock symptoms. So your nurse has recently took the PALS course, and she asked, do you want to give steroid? What would be your response? Yes or no? Do you want to give steroid? Yes, I'm seeing a lot of yeses for sure. Yes, and the new recommendation is for the hypovolemic shock, which is not responding to your fluid and vasoactive support, then it is reasonable to consider stress dose steroid. And the emphasis is more on patients which is at risk of adrenal insufficiency, your metabolic patients, like chronic steroid use patient, like your nephrotic patient, and patient with purpura fulminans. The most beneficial benefit is shown in these three subset of population, but it is shown that in some studies that the steroid shortens the time to reversal of shock. But it doesn't mean that you haven't considered the fluid, you haven't considered the vasoactive support, and you are giving considering steroid in for patients which are not fluid responsive, which are not vasoactive responsive. Then you can consider giving a dose of steroid, and it's not irreasonable. Perfect. So for cardiogenic shock, there's an recommendation for early expert consultation. It is also appropriate to start epinephrine as an initial vasopressor, which is a huge change. There's a lot of, when I was myself a fellow and working like early on when getting training, there's a lot of like start dobutamine, start milrinone, blood pressure normal versus blood pressure abnormal. It's still okay to be do, but as I said, a lot of these things being started as a first line in the emergency department led to many errors. That is why in the emergency department, it is even reasonable to start epinephrine as a first line of vasopressor for even for cardiogenic shock. If you are suspecting myocarditis or cardiomyopathy, then early consideration of ECMO or ECLS support is recommended. And always remember, if there's a cardiogenic shock, do not forget to do ECG. It is such a simple bedside test, but it will tell you a lot of information. So if you are suspecting cardiogenic shock, and if you did an ECG, if it is showing heart block, ST segment changes, or any other ECG abnormalities, then those patients at our higher risk of cardiac arrest. And always provide them early inotrope, always consult your IPICU early and try to transfer them to IPICU as soon as possible. Then in traumatic hemorrhagic shock, the emphasis is if they are hypotensive or they are demonstrating signs of shock, then fluid is the blood that they need. Because in trauma, we all know that the fluid that they lost is blood and blood products. So therefore, in traumatic cardiac arrest, you will not continue to provide them normal saline or ringer lactate. You will provide them blood and blood product. And as I said, when we do dedicated sessions on trauma management, we will talk about all the pros and cons and all the nitty-gritties of how that blood products look like, what is the massive hemorrhage protocol versus what is the protocol for giving normal blood product. Yeah, Akil, I'm not talking about the known patient for CAH. You will definitely follows all the protocol, steroid first. I completely agree. That's why it is for patients which are at high risk of adrenal insufficiency, and which means chronic steroid use for CAH. It's not specifically about the CAH. For CAH, yes, definitely you will not wait till the inotrope, till the fluid management. Yes, Fatma, when we use APLS, as I said, there are very, very small differences in European, North American, Canadian, Australian guideline. Please follow the guideline you follow. I am just providing you the rationale and the North American guidelines. So I know I always say, don't get stuck into starting doses 2 joules versus starting dose is 4 joules. The most important thing is if it is a shockable rhythm, you have to defibrillate them. And CPR and defibrillation, along with medication, is the mainstay of management. Literally, there is near to impossible to do studies whether 2 joules is good, whether 4 joules is good, whether 6 joule is good. So please get above that nitty gritties. If you are using 2 joules, you are correct. If you are using 4 joules, you are still correct. And if you are using as 4 to 6 joules or from 4 joule to 10 joule per kg, you are still correct. The most important rationale or the thing to understand is defibrillate if it is a shockable rhythm, continue CPR if pulses are absent, or start CPR and use medication. Those are the important things. So thank you so much, Fatma, for bringing that up. I completely appreciate bringing the differences in guideline, but do not fall in the trap that, oh, 2 joule is important versus 4 joule is important. It is the shockable rhythm which is important. Then coming to the opioids, the next important aspect is opioid. There's a lot of emphasis on the opioid overdose arrest. It is very important. Yes, naloxone is the antidote, but continue with your ABC and CPR is always your priority. So, no improvement or benefit on administrating naloxone in arrest for survival. So, focus should be airway and CPR. This is the nutshell or the key point here, that if the patient is in respiratory arrest, cardiac arrest, your still airway management and CPR has the priority. Yes, if you have a third person is available in addition to your airway support and CPR support, then you can provide an naloxone. Okay. So if you look at the algorithm, this is a lay responder algorithm. In the scene, this is not in the hospital. So always check for responsiveness, shout for nearby help, activate near emergency response, get naloxone and AED if available. If the patient is breathing normally, then you will always tap and shout, do the basic airway management, consider naloxone, because here the patient is breathing normally and airway is not a threat and pulses are present. But if the patient is not breathing normally, then start CPR, then after only give naloxone. So what I'm trying to say here is airway and CPR is a priority even in opioid overdose, and then if resources allows, then give naloxone. And this other algorithm for the emergency healthcare providers, it is the same, only if the patient is breathing it's not breathing normally, then you will check if the pulses are present, assess less than 10 seconds. If the pulses are not present, then start CPR. If pulses are present, then support the ventilation. So again, if even in the opioid overdose, you will have to do airway, CPR, and if resources allow, naloxone. Coming to the post cardiac arrest care, we sometimes forget that once the ROSC is achieved, our job is not done. We still have to continue support these 4 areas. That is respiratory management, hemodynamic support, neurological monitoring, and temperature management. So they have provided the whole checklist in the updated PALS guideline. And I know this is a big checklist. If you go and put it in Google, pediatric post cardiac arrest checklist, it will come up and you can upload it. It emphasize on oxygenation and ventilation as a continuous process, hemodynamic monitoring, maintaining the core temperature, neuromonitoring, electrolyte and glucose, continue sedation, and continue monitoring prognosis. But yes, it is outside the domain of emergency department and more applicable to the PICU and for to the floor before the patient get discharged. Remember, we discussed at the very beginning that the chain of survival has now included recovery. So, recovery is a huge part of PALS update, and they have talked about ultra short term, medium term, and long term recovery roadmap in the PALS guideline, and that is an important aspect that we should not ignore. And I agree, this is kind of a beyond the scope of emergency medicine or PICU, and it's more in the follow-up. But remember, in every hospital, we have to develop a system of care. And in system of care, recovery has a huge role. That is why it is important for us, because every hospital these have these cardiac arrest teams and cardiac arrest registries that they follow. So do not forget that initial management is very, very important. But once the child survives, then the recovery phase is also very important. The last part is they have done a very, very good job in improving the visual aids and algorithm. So let me tell you what is the visual aid and algorithm. So this is the pediatric bradycardia, like they have make it color coded, they have used different color combinations, they have put it very explicit yeses and nos, so which is a very, very good thing in the pediatric algorithms. And we will talk about a little bit about each bradycardia, tachycardia in a very nutshell. As you all know, these PALS updates or courses are full day, 1 to 2 day courses. So we will not be able to go into the depth of each and every algorithm, but I will tell you a little bit of nutshell that if there is a pediatric bradycardia with a pulse, then heart rate below 60 beats per minute with poor perfusion require immediate action. So if the pulses or heart rate is 60 and the perfusion is good, then you will continue monitoring, you will consult cardiology, you will look for H's and T's. But if the heart rate is less than 60 and there are signs of poor perfusion, then it is something you need to be worried about. So as I emphasized very early on in my first lecture, that the age appropriate normal age ranges vary very much in pediatric patient. So you need to know what is the normal heart rate and what is the abnormal heart rate. Also do rapid recognition and manage them immediately, because in children they may be just showing signs of poor perfusion as low energy or capillary refill time. So do early recognize them, reassess them immediately. Exactly, exactly. Perfect. Great, Muhammad Sarfraz. Very good comment. So, in bradycardia, initial assessment will be quick airway assessment, breathing, circulation, mental status, look signs for poor perfusion, which are altered mental status, hypotension later on, PALR. You should monitor them with the cardiac monitor and pulse oximeter, obtain blood pressure management, and continue reassessing their vital signs. Vascular access, either IV or IO for medication administration, and blood samples to rule out your H's and T's. Depending upon the history, you may consider doing the X-ray, you may consider doing the point of care ultrasound. So the treatment for bradycardia supportive measures are provide oxygen, support ventilation, identify causes, that is H's and T's, and continuous monitoring. Then yeah, this is kind of repetition, but in the medications which are used in bradycardias are epinephrine. You can give epinephrine through IV or IO. You can give it through ET tube, but the ET tube's doses are different. Second, third is atropine, and the fourth is the like last line is the maximum atropine dose. I know some guidelines say zero point 0.4, some guidelines say zero point 0.5. What is the guideline you are using? What is the maximum dose you can give atropine? Atropine is now not recommended as a routine, but if you are suspecting vagal maneuver, for example, you are intubating and during intubation the patient become bradycardic, then you can use atropine because you are suspecting a vagal activation, and that will, for that atropine may be a good choice of your medication. But otherwise epinephrine is the first line mostly used. The doses are different for IV, IO, and for ET tube. I used to memorize medication doses earlier, but now I think intubation is such a stressful, or resuscitation is such a stressful situation, that it is always good to have something in front of you, either a PALS card, either the Barslow tape, either your app that phone app that have all the doses, or either any other visual aid that is available in your departments. It is no harm in using those cue cards, your phone apps, your anything that is available in your department. Please do not only rely always on your memory, have them available in front of you. Then pacing and advanced step. Frankly speaking, if we go to those advanced step, we almost always consult our cardiology team. It is very rarely that we have used pacing in the pediatric patients. But if you have to use, you can start the transcutaneous pacing, treat the underlying cause, consult the specialist. And if that is the situation and you are not the tertiary care or quaternary care, you are primary or secondary, then please do or try to arrange the early transport. Okay, perfect. Thanks, Nusrat, for mentioning that. Atropine given here first in case of yes, completely agree. If you are doing intubation and your patient get bradycardic at the because of the intubation, then definitely atropine is your first choice for that situation. But if it is bradycardia because for any other reason, then we use epinephrine as a first choice. So the pulse of bradycardia is always look for primary cause, always look for the age consideration when you are looking for the normal heart rate responses, and then medication response is atropine or epinephrine. Then the tachycardia. Tachycardia is a complex algorithm. I would say the most common tachycardia, I will try to simplify, you can look at it on the internet, but my two take on this algorithm is, first, the most common tachycardia in pediatric patient is sinus tachycardia. And the second most common is supraventricular tachycardia. So these are the two things you should remember, that always look for any fever, dehydration, like H's and T's, I would say. So that led to sinus tachycardia, and the second is supraventricular tachycardia. So we will talk about the tachycardia overview. We will classify tachycardia as narrow complex tachycardia and wide complex tachycardia. And for that, we will take the QRS complex as less than or more than 0.09 second. This distinction will guide us the treatment approach and medication selection. The second thing that guide us what would be our management is the perfusion assessment. If the patient has a sign of poor perfusion, like hypotension, altered mental status, hemodynamic instability, that will determine the urgency and type of intervention. So at any point you come across pediatric tachycardia, two things to look: QRS complex, perfusion assessment. Is it a narrow complex tachycardia? Is it a wide complex tachycardia? Is the patient is having good perfusion or poor perfusion? And based on that, your treatment strategies will be described. So, as I said, for any algorithm, for any patient, your initial management will or assessment will remain the same. Sorry, not the management, initial assessment will remain the same. That is PAT, ABCDE, like vital signs, ECG, sample history, and then your like a head to toe assessment. So you did that and you find the either it's a narrow complex tachycardia and a broad complex tachycardia. So if it's a narrow complex tachycardia, it is either a sinus tachycardia or a supraventricular tachycardia. But if it is a broad complex tachycardia, it could still be supraventricular tachycardia with aberrancy or ventricular tachycardia. So this is, I know it is a lot of time confusing, but I'm trying to simplify. First, you look at whether it's narrow complex or broad complex. Good perfusion, poor perfusion. You after you identify that it's a narrow complex tachycardia, in narrow complex tachycardia, which is most common in pediatric patient, it will be supraventricular tachycardia or sinus tachycardia. If it is a wide complex tachycardia, it will be either ventricular tachycardia or SVT with aberrancy. Unstable sign we talked about, so that's why I'm skipping, because if the patient is unstable, then you have to prepare for cardioversion. Here you will set up the defibrillator for synchronized cardioversion. That is the most common point to consider here, that if the patient is unstable, then you have to proceed to synchronized cardioversion in addition to all the additional like vagal maneuver, adenosine, etc. If you are doing a synchronized cardioversion, administer sedation if time allows or if patient is conscious. And here the synchronized cardioversion is started as zero point 0.5 to 1 joules per kg, and you can increase to 2 joules per kg if needed. If the patient is stable, then your approach will be vagal maneuver, which is age appropriate, putting ice on the face in older children, Valsalva maneuver, taking the syringe and asking them to blow so that the plunger will come out, blow hard, or blowing bubbles. There are multiple maneuvers which is described. You can use any. Then the second is adenosine. The first dose is zero point 0.1 milligram per kg. Maximum is 6 milligram as a first dose. The repeat dose is zero point 0.2 milligram per kg and maximum is 12 milligram. I would say the patient should be on a continuous ECG monitor and the strip coming out, because it is very, very important to see the response of adenosine. Sometimes it is so short-lived that monitor are not able to capture. So what our cardiologists recommend us while you are doing it, it should be a continuous ECG strip that should be printing so they can see on the ECG whether there is a even a very minimal response for adenosine has happened or not. And then definitely once you are doing it, either your patient becoming unstable and not responding, you need a expert consultation. The method of giving adenosine is very, very important. There are multiple that are described in literature, but the most important is, you, as we all know, that the adenosine is very short-lived. So there need to be a two-way stopcock attached to your IV line. The IV axis should be as near to heart as possible. So the most common recommended place for IV access to give adenosine is left antecubital fossa. And it says that take your adenosine dose and the 10 ml flush. And there should be two people, one giving adenosine and one giving the flush. And they need to coordinate. And as soon as they have given, just pull, make your arm rise. And this is for the reason that adenosine is very short lived. And by doing so, you can give adenosine very quickly so that it will reach to the heart. So I will repeat again, giving adenosine, you need to be on the left antecubital fossa. You need to have two people, one giving adenosine, one giving normal saline flush, preferably 10 ml, and then you will coordinate, give adenosine, give flush, and raise the arm up. So this is the proper administration of adenosine is considered so that it will reach to the heart as soon as possible. Yes, near to the heart. Completely agree, Nusrat. And that's why the left antecubital is kind of preferred one to be considered. And one thing which I was asking, if you have an IO, can you still give adenosine or not? Yes or no? If you have intraosseous line, yes. Nusrat, thank you so much for putting in the chat. Yes, if you have a IO access, you can still give adenosine. There are some case reports, although theoretically, if the IO is in the femur, you can imagine how far away it is from the heart, but they are saying it is effective. That's why if you have noticed that there is a role of humeral IO that is coming into the pediatric patients as well, because nowadays even the EMS, when they bring the patient, at least here, a lot of time the femoral or sorry, tibial IOs have already been done by the EMS, because on the scene that is the most easiest one to get. So that's why sometime if we are not able to get an IV access, we put the humeral IOs. Yeah. So as I said, adenosine is a stable wide complex approach. You will give adenosine, first dose 0.1 milligram per kg, maximum 6 milligram. Second dose is zero point 0.6, zero point 0.2 milligram per kg, maximum 12 milligram. And the antiarrhythmic option for the tachycardia, which is a ventricular tachycardia, but with pulses, is either imidron or procainamide. Never combine these medication. You can give either. There are multiple like institutional preference. There are very, very minimal studies that will say one is better than the other. So if you're giving imidron or procainamide, both are fine. And but the key here is start getting expert consultation, watch for the deterioration sign, and if there's a deterioration, then you will always consider synchronized cardioversion, and synchronized cardioversion is zero point 0.5 joules per kg, zero point 0.5 to 1 joule per kg as a starting up shock, like a cardiovert energy dose. Then if it is a wide complex tachycardia, again, identify the rhythm by doing an ECG, determine instability, determine antiarrhythmic medication, and cardiovert if unstable. So yes, this we have talked about. Now coming to the cardiac arrest. As we talked about bradycardia, then tachycardia. Now the last one is cardiac arrest. Cardiac arrest in pediatric patient is usually secondary to respiratory failure rather than the heart causes. And adults have more commonly primary cardiac events as compared to pediatric, as we keep on talking about. Therefore, the respiratory or ventilatory rate has been changed, and it is now 20 to 30 breaths per minute. Other factors which will improve the outcome is the high quality CPR, as we talked about earlier on. But just important thing, always start CPR immediately if pulses are not present. Activate the response. If you are on the scene, it will be EMS. If you are in the hospital, then there are code blue teams in the hospital. You will activate them, get your equipment, either AED or defibrillator, attach monitor, or do ECG, whatever is the possibility, to identify the rhythm, which is very, very important, because in identifying the rhythm, you can have either ventricular fibrillation or pulseless VTAC. It could be asystole or PEA, and both of their management is very, very different. So if it is a shockable rhythm, which is your ventricular fibrillation or pulseless VT, then you have to defibrillate. And as we talked earlier, defibrillation is 2 joules per kg, second is 4 joules per kg. You can choose to continue 4 joules, 4 joules, or you can continue choosing increasing the energy up till 10 joules per kg. So this is CPR, check rhythm, provide shock, give epinephrine as soon as possible, and then give antiarrhythmic medication. While if it is asystole or pulseless electrical activity, then your treatment choices are high quality CPR. You will give epinephrine as soon as possible, and the repeat dose is every 3 to 5 minutes, and then actively search and treat for H's and T's. And again, these are the doses. You can always look at it. As I said earlier, I never tend to remember these doses. I always use my cue cards or some visual aids so that I'm not giving a wrong dose. But if you want to see those doses, this is there on the slide, and you can always like do not hesitate. We do not have to memorize everything. We need to know what is important next steps, but we are allowed as an emergency, as an ICU, as any type of physicians who are managing acutely sick or acutely injured children, to use always visual aids. And this is again the visual representation of H's and T's that you have to remember. Do not forget them. So with this, I would say these are the whole about very, very brief about what are the updates, what are the changes that have happened, and very briefly the algorithm. I would say the three points to remember, which we often follow or do not pay attention, is quality CPR. High quality CPR is a key for ROSC in pediatric patient. Then we sometime continue to pay attention to all the other aspect, but we forget to look for reversible causes, that is H's and T's. Simple is, I cannot tell you how many times we as a team forget to check the glucose, and all the reason of hypoventilation or bradycardia was hypoglycemia. And as soon as hypoglycemia was corrected, the patient was very becoming starting to become alert, or dehydration. So always look for reversible causes, and the most common cause of pediatric cardiac arrest is respiratory rather than primary cardiac cause. And I'm not talking about complex patient. I'm not talking about the patient who have already existing or known cardiac causes. Definitely in them, you will always think about cardiac causes as a first if they have a history of heart disease, or if they are cardiac transplant patient and those kind of complex cardiac problems. So I'm talking about a healthy child. The most common cause of arrest is respiratory in origin rather than cardiac in origin. Yes, the recording will be available. You can all watch Masab, the recordings on the YouTube. Please, I will ask everyone to go through. Yes, thanks, Dr. Shakil, for sharing the AHA 2020 guidelines. The whole guideline is 70 plus pages. So this is kind of a summary of the nutshell. But if you want to read more in detail, what is the rationale, what is the level 1 to level 3 recommendation, definitely those guidelines are the best to go through. So I would like to emphasize here that PALS has done a very good job to provide algorithm which are very, very visually intuitive. You can see this pediatric basic life support algorithm, the chart. So it is so simple just to print, laminate, and put it there. See, for the basic life support, they have make it so simple. 3 steps: step 1, step 2, step 3. They have also shown how to put how to place your hand for CPR by either a palm method, like a hand method, or the 2 finger method. And then this is another example of how algorithms become very, very clear, that even by seeing them, they have color coded. They have put some, like here, if there's a shock, they have put a kind of icon for shock. For epinephrine, they have put an icon. And even for the tachycardia algorithm, which is always very difficult to understand, they have color coded so that you can follow them. So afterward, the last thing which I want to talk about is the emphasis on education. And that education is need to be beyond just lecture based or classroom based. It need to be, I would say, you can argue that I am biased because my interest is in simulation based education. But frankly speaking, I haven't put my own thing. There is, the PALS has recommended all these 4 points that we should do: deliberate practice and mastery learning in our units or in our centers to promote outcome or to improve the outcome of cardiac arrest. And they are recommending in situ education with gamified learning and virtual reality to help develop system of care. And remember, system of care start from prevention, early recognition, to the recovery. So that is why if we want to improve the overall outcome, we have to develop the system of care, and we have to develop educational strategies which are beyond the lecture based or classroom based teaching. So I thought to describe a little bit about team training in situs or in situ simulation. So what are in situ simulation? These are the simulation which are physically integrated into the clinical environment. Like, it is one thing to learn about CPR, practice about CPR in the sim lab, and I will give this whole credit to Jonathan Perry, who is my who was my mentor as well as my fellowship program director when I was doing the fellowship, and he has implemented the team training in situ long back in our department. So what we do 12 scenarios every week between 8 to 10 in our emergency department. And the teams which are working in the emergency department participate in those team training in situ to test our teams. Are they able to work together? Are they able to work together effectively in the actual clinical environment? And for us, it is emergency department. That's why emergency department is where the in situ team trainings are happening. But it is happening, it can happen in the PICU, it can happen on the floor, it can happen in the clinic, because patient can code anywhere in the hospital. We use a case specific checklist for the case in specific, but we do talk about the non-technical skills, which will talk about the team dynamic, the teamwork, the leadership. Again, we have been very lucky to develop, like someone say, during COVID, as well as during opportunities where either you cannot have experts in your department, and you need some virtual help, in combination or in collaboration with the teams from McMaster University, from Trillium Health, that is Sarah Fuhe, James Lewing, and Alim Nagji, we are able to create this virtual resuscitation room where we have been doing these simulations long with Pakistani institutes like Indus Hospital Health Network, and that they come out of necessity during the COVID time. So it's very simple format or simple application that will require your laptop, a Google slide based room, and a Zoom to communicate audio video. So it will they have a resuscitation room that will look like a resuscitation room here. It has a medication cart, an airway cart, and I will show you a short video how does the virtual resuscitation room work. And this is a Sarah Fuhe who is describing it, so let's watch this video.
This is the virtual resus room. First, it uses Zoom. Zoom can provide the audio and the visual so learners and facilitators can communicate with each other and mime actions like CPR and the all clear. The virtual environment is created by a Google slide. All the learners and the facilitators will simultaneously open up and enter the same Google slide document and make synchronous edits that are viewable pretty much instantaneously by everyone. I want to emphasize this. This is not a screen share. This is a collaborative document, so everyone can be simultaneously making changes like putting on monitors and putting on oxygen and typing in a text box, doing the same actions that you would do in the sim lab. This all makes more sense when you see it in action. Let's check it out. Begin by applying monitors. Learners apply monitors by clicking and dragging the image of the monitor into place over the patient's body. As this happens, you can see the facilitator typing in the vital signs in the text box of the monitor on the right-hand side. Next, get access. Place an IV by clicking and dragging the IV over the patient. Difficult poke, you can show how to do an IO by landmarking and then walking through the steps of the procedure. Assess the ABCs and examine your patient.
If I take a look at his face and airway, what do I see?
If you go to slide 4, you can see a picture of what his face and upper airway looks like. And if you press play, you can hear an audio of his upper airway sounds.
Thank you. So Marley, I see a little boy who is awake and alert. He has some obvious swelling around his mouth and a rash on his cheeks. This is what I hear.
Manage your patient's airway. Click and drag the oxygen into place on the patient's face, then choose your flow rate. To grab extra airway supplies, go to the airway tray on slide 3, copy what you need, and paste in place onto slide 1. Organize at the head of the bed like you would in real life. If the patient's still hypoxic, you might set up high flow or type in the settings you need to start BiPAP. If they need intubation, you can see what your view is on GlideScope. Give medications. Go to slide 2, your medication tray. Copy the med you'd like, then paste it in place on slide 1. Drag it into the medications given box to show it's in the patient. Use machines. You can cardiovert your patient.
So oxygen, I'm going to take it off.
Excellent. So are we all clear? Clear.
Clear.
I'm clear, you're clear, the oxygen is clear?
Point of care ultrasound has been integrated. Look at the image and describe your finding. Do procedures. You can do procedures like this Craig by clicking and dragging pictures of equipment and then using landmarking lines to show where you would make your incisions as you describe your steps. Let's see it in action with the perimortem hysterotomy.
I'm just going to make another vertical incision, just like a nick with my scalpel, and use scissors to open up the uterus.
We're at 2 minutes.
Work as a team, divide into roles, and communicate clearly.
So Sarah, if you don't mind giving 8 puffs of Ventolin to this baby and let me know once that's been done. And if you could auscultate and let me know if his wheeze has improved, that would be great.
And just confirming the Benadryl as well as the ranitidine and methylpred have been given.
Thank you so much for listening to me share the virtual resus room.
So you can imagine we are able to do distantly, although it is with the short teams. So I will show you the curriculum that we are able to do it with Pakistan in a minute. But I would like to now talk about a little bit about our SimKIDS simulation program. Our simulation program, you can see this building as I showed earlier on in my slide, the first slide last session, that at the basement, we have this Sim Center, amazing Sim Center. If you want to look at more details, you can scan the barcode and it will take you to our Sim. Basically, we have our Sim program from 2009. I joined in 2016, and since then I am working with the team. It is accredited by the Royal College of Physician and Surgeon of Canada since 2013, and our last renewal happened in 2023. We do have, it is 11,500 square feet Sim Center, which is opened in, like we have a new space in November 2023. Before that, we have a small area of almost 1,600 square feet. And still you can see that even in that space, this is the number of the learners we used to have. So what I'm trying to emphasize here, cool, good looking spaces are good, but you can still do a lot of things with very little or no space as well. So with that, I would like to show you a video of our new Sim space, which we started in 2023 November.
Welcome to the SimKIDS Simulation Center. The center is a multifaceted space that fosters immersive learning through tailored simulations. There are 5 multi-purpose training rooms that can be used to host large groups for simulations, workshops, or conferences. Each training room features movable furniture, ceiling-mounted projectors, audio-visual equipment, and patient head walls. These rooms can be set up for various learning objectives like mass casualty events or team building exercises. We have 6 OSCE suites available for diverse simulations, and each are equipped with cameras, microphones, and speakers for recording and playback. These suites can be used for assessments, evaluations, and training in interprofessional education and communication skills. Next up is the Immersive Reality Room. This room features 360 images or videos with interactive.
So this is a very special room, the immersive room. I will show you another separate video. In addition to the virtual reality, what we found that is most valuable for us is how can we create an immersive experience for our learner. So it's a room whose 3 walls get converted into any environment. So right now, these are the walls on which you are seeing our Sim Center, and I will show you a separate video that will give you more idea what does this immersive room look like.
Hotspots projected onto 3 walls, mimicking realistic and immersive scenarios to enhance the simulation experience. There are 4 high-fidelity suites, each with a different key feature. In Discovery, you will find an operating room setup with functional gas machine for simulating anesthesia administration and monitoring. Our high-fidelity suite Adventure is a single patient room and features a patient chairlift and ensuite washroom. This feature enables the learners to simulate scenarios related to patient transfers and home care environments. Next up is Quest. This high-fidelity suite holds up to 2 patients and features an adjacent negative pressure room with a functioning Omnicell for medication preparation and dispensing, as well as a workstation on wheels. This setup is ideal for acute care, emergency, and infection control scenarios. Our last high-fidelity room, Curiosity. Although it mimics a standard single-patient room, this room comes equipped with a dialysis spigot that can be used when a scenario requires the patient to be put on hemodialysis. There are 4 debrief rooms where observers can watch live stream scenarios from each of the high-fidelity suites, allowing them to participate in the debrief. Each room is equipped with a large screen, speakers, and microphones for feedback and reflection. Last, we have the Invention Lab. This is where the simulation specialists use innovative thinking to design and develop custom task trainers using 3D printing and silicone molds.
So this is a little bit about our sim center. These are some of the sim spaces which you already see. We try to have all the equipment which are because we are hospital-based sim center. So we have all the equipment that mimics the exact equipment in the hospital. So when they learn with us, they are going and performing or doing things in the same equipment, because there's no point of teaching them on a different equipment and then expecting them when they go to their workplaces, they have a different equipment to practice with. So these are some of the mannequins. You see our mannequins are not all are high fidelity or high technology that they can speak, blink. We do have many low fidelity mannequins, because it is not always that if you have a high technology or hi-fi mannequin, only then your simulation can be amazing. And then as I will go forward, I will show you how in Pakistan, with very small resources and very low technology, homemade mannequins, homemade stuff-based made equipments, how we are able to achieve a lot. But it is just to show the contrast that sim program is not about definitely in an ideal situation, if you have all the resources, then having these sim centers, big spaces always help, but things are possible in every setting. So what we offer in our SimKIDS center is we offer simulation fellowship, simulation certificate courses, and electives. If you want to know more, this is the barcode and you can go to that. You have to apply, and unfortunately right now you need to have your own funding. But through medical school, you can always apply for electives, which is easier. And certificate is for 3 months and fellowship is for whole 1 year. Then coming to the immersive room, which is I'm trying to say, even in the benefit of these immersive room is we are creating some escape rooms, we are creating some interactive opportunities for our learner. So just watch this immersive multi-purpose room to get a sense that how we are doing it.
Welcome to our immersive multi-purpose room. Interactive projection technology immerses users in realistic simulations. From busy critical care.
So you can see it looks like a critical care environment, although it's just a video of the critical care, which is displaying on the walls, and you can put in between because this is a room. I know in the video it is not clear, but you can put a mannequin and you can run the simulation here, and it will be felt as you are in the ICU. So even if I am in this room, I can do I can bring the ICU, I can bring the CT scan room, I can make it whatever environment by just having a video or pictures of that environment.
Units. To our own SimKIDS CT scan room. Helping our clinical teams practice safe, patient, and family-centered care. Our acute care transport service simulates realistic scenarios above the clouds. and you can even prepare for an emergency response on public transit. We run engaging, team-building exercises, such as our high school workshop for students interested in STEM, where students engage with quizzes to learn about medical terms and equipment. Or emergency scenarios practicing the care of a child, from ambulance to emergency room. To our latest venture into escape rooms, where learners solve educational puzzles and quizzes. To escape. The sky is the limit when it comes to interactive learning experiences.
So this is a little bit about the immersive room.
Welcome.
And then if you want to stay connected with us, please follow us on LinkedIn, and you can continue to know what other offerings we are offering. And if any one of you are interested, more than welcome to come visit our Sim Center. And I'm happy to give a kind of in-person tour of our Sim Center. Now, coming to the places where the resources are not as extensive as I have shown you. So, which is a Pakistan context. And I'm very blessed to have an amazing team to be present at Indus Hospital Health Network, to be enable me by all their hard work to bring simulation to countries like Pakistan. And we all know it comes whenever we go or plan to implement simulation-based education, it always come up that simulation is costly. But remember, we are very good in doing jugaad, which is a Urdu language word, but it means innovation, making a or bringing local context, which is cost effective. And some of the examples are, this is like the old medication bottles which are empty and they are using it for sim purpose. These are the defibrillators they have created from the brushes. This is the from the gloves they have created this hand or finger injuries. Then this is a cricothyroidotomy model that they have created with a simple homemade equipment. It's a laundry basket that was converted into a chest tube, because remember, laundry basket has holes which can mimic as a in between the ribs holes. Then with a golf ball and a paper cup, the lateral canthotomy models were created. This is like an IO model. They have created pajama model for practicing giving delivery. And this is a lumbar puncture model, which was created by using simple the homemade clips that we use it to make our clothes to dry up. So this is a lumbar puncture model was created. And then you can see all the moulages which were created by using simple techniques. This is an ultrasound guided model, which the Indus team, I would like to acknowledge here, Adil Khatri, who is kind of a person behind all this huge innovation and out of box thinking. They were doing Code Orange, single hospital, even national level Code Orange tabletop exercises by using just Lego figures, a map, and different color coding. So by doing these, you can see in this video, a disaster drill is being, or a code blue is being announced. And this is what from 2018 up till now, we are able to achieve. And I'm only sharing one of the study where how much impactful it is on the education of the emergency medicine resident. So we did this need assessment where we asked the EM residents at Indus Hospital how comfortable they are, how much they have participated in pediatric resuscitation. So almost more than 50% have not participated. And this is study many, like almost 3-4 years ago. So that was the situation when we started doing simulations and implementing the simulation-based PAM curriculum. then almost more than half have never led a PEM resuscitation or pediatric resuscitation as a team lead because they are so hesitant. And you can see how many resuscitation led as team leader. So none in almost more than a half. When we ask them how confident they are, more than 51% said they strongly disagree that they are confident, but 100% of them agreed that they need simulation-based education. And at that time, suddenly COVID hit. So we asked them, are they open to use a virtual platform? And almost more than 80% said yes, they are willing to try virtual platform. And we started doing these resuscitation by using the virtual resuscitation room, which I showed you earlier. So you can see the change in knowledge was huge. We did it like we captured the data for 2 years, 2021 and 2022. So first time they did in 2021. Remember, emergency medicine is a 5-year residency program. So the 2021 up till year 4, then 2022, the year 4 become year 5, and there were new year 1 that come in. So some of them did it 2 times. Even doing it again in the next year will bring a change or improvement in knowledge. So first time participation bring a huge knowledge, and then second time participation brings still improvement in the knowledge. Their OSCE scores, almost more than 74%, exceeded the expectation. And we, for the first time, try to incorporate the team dynamics or crisis resource management in their training, where we teach them how to work as a team, how to be a team leader in a resuscitation scenario, and how to work together with the interprofessional team. And I know it's a complicated graph, but do not get caught into the different colors. Just focus in this red dotted line, and you can see in the leadership domain over the 7-week curriculum, their leadership qualities, their teamwork, their task management, and overall performance get a lot better from the baseline. So, and we got a lot of good impact from the end of session evaluation, high satisfaction, safe, non-judgmental environment, and the overall impact which continue to grow. And these numbers are a little bit now old, but almost 500 interprofessional teams were trained in basic emergency care, trauma care, and PEM, with the involvement of many national, local, and international faculties, and it continued to grow. And I would like to acknowledge, this is like I only supported, this is the huge work of Indus team in Pakistan, especially Adil Khatri, and I would like to mention his name. So just watch the video which Saima Ali, who is the head of the department of Indus Hospital, has described some of the work at Indus Hospital. So let's watch this video.
My name is Dr. Saima, and I'm one of the consultants at the Department of Emergency at the Indus Hospital, Karachi, Pakistan. Working in a country with a population of more than 200 million and based in a city which is the 5th most populous city in the world, our challenges are numerous. From overpopulation to underprivilege, from lack of basic healthcare facilities, leading to untoward events, lack of infrastructure, lack of manpower in healthcare, and the recent pandemic with urban flooding. Our challenges are numerous.
Here at the Emergency Medicine Department, me and my colleagues, we aim to bring about change in the emergency care delivery by training young aspiring EM physicians in terms of clinical research, with evidence-based training programs inculcated with simulations.
These challenges are what make us strong. We face them together as a team, through our resilience, through our capacity building, through our focus on the future, through training our future EM physicians. And we strive for it every day.
So you can see that just by not having resources is not an excuse. You can be creative, and simulation is creating an experience. It's not about always having a hi-fi instruments. And then I would like to highlight here our national project that we worked with India for national implementation of a trauma resuscitation management program. I know we are just going toward trauma, but I just want to tell you that how that program get implemented. This is what we offer. Because trauma in India, and that is true for Pakistan as well, it's always that we learned there's one chapter in ATLS, and that's all about pediatric trauma. But what we felt, there was a faculty who got a grant, Neha Thakur, and this is her project, her baby, and I was the international advisor and support person on that project along with Dr. Qasim and Dr. Prashant Mahajan from USA, and we all developed a full training program, train the trainer course, and the big pediatric trauma resuscitation manual, followed by training in India that happened in November of 2023, where there was a lecture based and sim based, and we were able to train almost more than 70 train the trainer faculty member to go back and teach, and that was all with a very low resource in the classroom based setting and low cost mannequins. Just watch this video which is showing some of the part of the training. We did a multiple combination of screen-based, low mannequin-based. So it's a various combination, and a lot of local institutes and local companies like Ledol, etc., supported us in conducting. And then in that way, we are able to achieve a lot. So after this whole kind of sessions, I would say the key take-home points is high quality CPR, as I said, give early epinephrine for patient in non-shockable rhythm. Even if you have a naloxone or opioid overdose, respiratory arrest and CPR is the priority in the airway management. Rate of 20 to 30 breaths per minute. Do not underestimate the bag mask ventilation. Always consider bag mask ventilation as your first way of providing rescue breaths before considering intubation. Be prepared and then intubate. We will talk about more nitty-gritties when we take a respiratory emergencies lecture. Consider a cuffed endotracheal tube. It is safe to be used even in younger babies, and do not routinely use the cricoid pressure. Post cardiac arrest care is very, very important. That will entail normal blood pressure, normal glucose, normal oxygen, not hypo or hypocapnia, temperature monitoring, EEG monitoring, and then continuously monitoring the prognostic features. Then, improvement of resuscitation is a whole system of care at the community level, at the hospital level. So if you look at the community level, it's rapid recognition of cardiac arrest, having technological support. That is, people know whom to call, where to call. Like we have 911, and now in Pakistan also there are standardized local numbers where you can call for help, to call for a first responder. Enhanced role of emergency telecommunications, and then widespread CPR training of your general population. And on the hospital level, recognize and stabilize patients who are at risk of arrest. Always continue to monitor and look at the prognostic factors. performance measured. For example, at our hospital, we have our CPR data, which is maintained, and we monitor that for every cardiac arrest that happen in the hospital, which are done through clinical debriefings, either hot, warm, or cold. So with this, these are some of my references. And if you want to email me with some other information that you want, please do not hesitate. These are my email address. And I believe this is the link for my LinkedIn personal page if you want to follow me on LinkedIn or want to explore further some aspects which I have described. Please do not feel free. Please do not hesitate to reach out to me. I know it's a kind of a higher level overview, and there are multiple nitty gritties that goes into each aspect. Even, for example, shock, we used to teach like almost 2 hour session on that, airway management similarly, and we will plan to do that with Apna team. With this is what I have to share with you all. I'm happy to take any questions that you have once I have finished. And it's 20 minutes or 18 minutes to the finish of session. If you have any question, comments, I'm seeing a lot of comments here. Thank you so much. I appreciate it for all your expression, and I'm very humbled. And this is, I will again say, this is the work from many people who work with me. So I'm blessed that I have people or teams with me who are able to achieve and make me achieve. Thank you so much. Yes, Fatma, I see your question. How can we register for the virtual simulation session? We are not offering it right now, but yes, if you are in, if there is an interest, definitely we can look into that. If it is implemented dedicatedly to the people, like for example, Indus Hospital reach out to me that can we do virtual simulation. We do offer in Canada some of the sessions for our rural areas. But if you have interest, Fatma, if you have team, like for example 5 or 6 residents who are interested, reach out, and then we will see how we can plan for that. But we are not doing any specific ones. Okay, online PhD opportunities. Yeah, please reach out to me on my email. I will provide you more information about that. So this is my email addresses. I'm putting in the chat again. This will be, the recording will be available for those who are not able to attend the full session, or there's a, as I said, I have provided lot of information in this 2 hour. If you want to go back, revise certain aspect, you can go back and look at it again. Fatma, I haven't decided that. It will be shared. Let me finalize the dates and then it will be shared. Next session dates are not yet announced, but the plan is to take a session on shock management, pediatric shock management, pediatric airway management, and then possibly talking about a little bit either trauma or neonatal resuscitation. So this is a plan in progress. I just want to see first if there's an appetite, people are interested by doing this, and then I thought I will plan it later. Thank you, Sadia. I appreciate it, and stay connected. We have a WhatsApp group, we have the YouTube channel, and you will continue to learn more about the offerings that we offer through the Apna Academy and Apna Merit. These are the 2 platforms. Yes, sure, Saida. I will try to talk about the neonatal resuscitation, but I will say it again. My perspective will be emergency department perspective. I'm not at all a neonatologist, but yes, how we will manage in the emergency room, that perspective I will share along with the most updated guidelines, definitely. And if you need to know more about any aspect, as I said, contact on the email or follow me on my LinkedIn page, and as well as the SimKIDS LinkedIn page. Thanks, Amina. Can I ask the help of our admin support here? Can we share the link of the YouTube channel for Apna on which they can be able to see the recording? But usually recordings get shared with me as well, the link of the recording, and I usually reshare with those who I have shared the session details. So I will be able to share with you all. If anyone has no question who are in the session, they are more than welcome to leave, enjoy their time with their families. And as I said, I'm very, very appreciative of each one of you who take a time on Sunday, either afternoon, evening, or late evening to come and attend and to learn, which shows your commitment to learning and providing best care to pediatric patient. So thanks for all of your hard work, all of your amazing work in whichever setting, and your commitment to learning. I really appreciate it. Yeah, thank you for sharing the YouTube channel. You can see the link of YouTube channel in the chat. You can join and then subscribe to it, and then you will get the sessions recording there so that you will be able to see it at your own convenient time if you are not able to listen or attend the full sessions in live. Perfect. If there's no more question, I'm happy to close the session. Thank you so much. Take care of yours. Stay healthy, stay blessed, and remember each other in your prayers. Take care. Allah Hafiz. Goodbye. Assalamu alaikum.